بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meeting. This is a very special day as we have two distinguished moderators joining me in this session, and one of our very eminent speakers and the President-elect of the Egyptian Society of Nephrology and Transplantation in this session. We are dealing with cardiovascular disease in advanced CKD, which contains hemodialysis. And when we speak about hemodialysis, we are to go to Professor Hisham Sayed, Emeritus Professor of Nephrology and Transplantation at Ain Shams University and the President-elect of Egyptian Society of Nephrology and Transplantation. He is the Afran Hemodialysis Chapter Chair and the ESNT Hemodialysis Chapter Chair. Welcome, Professor Hisham, to speak in this session. And I will leave the floor to our great moderators, my two colleagues in this. This is a session of الطوارق. We have two Tariqs, Dr. Tariq Tantawi and Dr. Tariq Medhat. Dr. Tariq Tantawi is the Vice President of Gharbiya Association, Nephrology Association. He is currently a nephrology consultant in Mansoura Specialized Hospital, and is the Afran Registry and ESNT Registry, one of the very active group members. And Dr. Tariq Medhat from Professor of Nephrology in Mansoura University, and he is joining us for the first time in this session, and I am welcoming him and hope to continue to join us in these sessions later in more and more sessions. So I will leave the floor to my dear Tariqs. And before I leave, I want to thank Dr. Hazem Abu Shusha, our coordinator today, for all of his work regarding CME chapter activity. Dr. Hazem is a nephrology consultant and one of the fellows of the Egyptian Fellowship of Nephrology of Ministry of Health. So please, Dr. Tariq Tantawi start, and we'll follow Dr. Tariq Medhat, and then Dr. Hisham will go on and in his lecture, and I will come to you for the discussion after the session, inshallah. Please, Dr. Tariq Tantawi.
Many thanks, Professor Yasser, for your kind introduction for us. Actually, you did the best for continuing this CME and a lot of benefits for our colleagues in nephrology practice in Egypt. Today طبعا دكتور هشام السيد غني عن التعريف, and he will tackle an important issue in our daily practice about cardiovascular disease in advanced CKD. Cardiovascular disease is the leading cause of mortality among our population, and actually the challenge is to highlight an important issue to improve our care for our patient in that hard challenge. Professor Tariq Medhat, you can.
السلام عليكم.
عليه السلام.
بداية أشكر دكتور ياسر شكرا جزيلا على التقديم وعلى دعوتي. ثانيا أنا متأكد إن احنا نستمتع جدا النهارده بمحاضرة شيقة، خاصة معانا يعني دكتور هشام محاضراته معروفة طبعا. والحاجة التانية الموضوع الحقيقة تقريبا updated، مش عايز أقول monthly daily، تقريبا في continuous updates بشكل غير طبيعي في الموضوع ده بالذات. وبعدين العنوان الحقيقة في تحتيه ايتمز كتير قوي. أنا من امبارح قاعد أفكر الدكتور هشام هينقي أنهي ايتمز في دول. فأنا منتظر ومتشوق أعرف حضرتك اخترت موضوعات إيه.
هنشوف.
متشكرين جدا على المحاضرة مقدما يعني.
إن شاء الله إن شاء الله.
Okay, thank you very much for all our dear friends, Dr. Yasser Abdelhamid, the machine of the CME in Egyptian Society of Nephrology and Transplantation, as well for the African critical care and acute kidney injury. And congratulations for the Kidney International publication, Yasser. It's a very amazing publications for the Afran recently this month.
Thank you.
Also, I would like to thank my dear friends Tariq Tantawi and Tariq Medhat for their joining us in these very important topics. Also, I would like to thank Saeed Khamis and other colleagues and who are on the floor and giving us the time for learning. So I am very optimistic that this decade for an optimum educational materials, and indeed we are going for more and more, inshallah. For this topic, I tried hardly that to cover all the aspects of cardiovascular disease and advanced CKD, coming from the pathogenesis up to the guideline-directed medical therapy and what's the update on such lines. So let us have here, we have 6 points to cover, and each point will be highlighted. We will cover age and gender in heart failure, major adverse kidney events in cardiovascular diseases, diuretics and diuretic resistance and CKD, volume overload and arrhythmia, and intra-abdominal hypertension, and finally the guideline medical therapy. So guideline-directed medical treatment of heart failure and CKD, and finally our job of the dialysis and the mechanical ultrafiltration and patient on dialysis, how and to improve the volume status and the cardiovascular effect. So let us have here, we have here in this talk huge challenges, and these challenges for decades with no solutions. We have to find the diagnosis of cardiovascular disease with different phenotypes, and the panic of the nephrologist unusually for keeping the kidney alive and the patient died from heart disease. So we have to stop panic from the contrast unless it is highly indicated for the coronary angiography. We have also challenges in advanced CKD because cardiac biomarkers are different in CKD rather than in normal populations. We will tackle also the heart-kidney crosstalk in the pathogenesis between both. And on dialysis, we will tackle two phases of improving or worsening. Dialysis can improve and even can worsen the condition of heart disease, and how to prescribe in heart failure for the hemodialysis safety. And finally, we have the guideline-directed medical therapy. No rule is the rule in end-stage kidney disease, and I will highlight why I put this item, no rules in the rule of end-stage kidney disease for the guideline-directed medical therapy. So I will start from the last point that there are many of the controversies, conference on the kidney and the heart failure from the KDOQI guidelines started 2017 by frequent meeting about the controversies and the management of patients with heart disease and especially heart failure among advanced CKD. And last one was in Vancouver, Canada, 1 year ago, and they have settled many of the points that by definitions of heart failure and heart disease in CKD, we have a special entity and subgroups for patients with advanced CKD and on dialysis. We have heart failure with preserved ejection fraction post non-dialysis, and the dialysis, we have heart failure with reduced ejection fraction, and we have also heart failure with reduced ejection fraction and the dialysis-dependent CKD, and finally heart failure in kidney transplant patients. All of these items should be fulfilled by special guideline-directed medical therapy. What can be applied in CKD may be not applied in patient on dialysis. The best example is the sodium glucose co-transporter and MRA. And the reverse occur. For example, for the transplant patients, what's the guideline for using sodium glucose co-transporters up to now? So we have a dilemma of sub or phenotype of the heart disease and heart failure with different kinds and different phenotypes with chronic kidney disease. Thus, the guidelines should fulfill all of these items. Still, up till now, there is no consensus clearly to settle the management or better management in all these subgroups and all these phenotypes. So, in these guidelines, or Vancouver, Canada, they discuss the bidirectional effect of heart failure and kidney disease. It's like a pendulum between heart failure and the kidney. Each augment each other. They discuss also there is a specific phenotype of kidney disease and heart failure driven by comorbidity, such as obesity, diabetes, or hypertension, and we'll come in a minute in that. Or we have to decide that we have heart failure with preserved ejection fraction or reduced ejection fraction, or another phenotype, heart failure with advanced CKD, should be highlighted. What is the role of elevated central venous and intra-abdominal pressure and the decreased cardiac output? And are these of equal importance? And I will highlight again the intra-abdominal pressure, how it's play in the pathogenesis of acute and chronic kidney disease, and what is the effect on the heart, which is recently described, and I think it's a new item for nephrologists to learn about intra-abdominal pressure and abdominal hypertension. And finally, is there a distinction between the importance of glomerular, cystatin, and creatinine-based estimate of GFR versus tubular function in heart failure and kidney dysfunction? And some recommendation using cystatin C or combined creatinine cystatin C in evaluation of the estimated GFR may be applied in patients with heart failure, better than only creatinine. And for the diagnosis of heart failure in patients with kidney disease, like imaging, biomarkers, and I will discuss that again, role of biomarkers in case of advanced kidney disease, and what is the importance for the cardiac disorders, and what is the available now and what is on the horizon. So we have a lot of questions still not answered. I will try to answer what I have, or what is the globe have. So one of these major for diagnosis of heart failure with preserved or heart failure with reduced ejection fraction is to monitor natriuretic peptide. However, in CKD patients for different diagnoses, does the accuracy of brain natriuretic peptide change as CKD progress? Yes. So this marker may not be available for patients for diagnosis of heart failure with advanced CKD. And how are brain natriuretic peptide measures affected by other comorbidities in patients with kidney disease, like atrial fibrillation, obesity, and others? So I think all of that should be highlighted. And one of the best statements in this condition that the consideration of guideline-directed medical treatment in patients with kidney disease, including adverse effects. For example, mostly will have hyperkalemia for MRA and ACE or ARB, or monitoring schedule, or are therapies to be avoided in kidney disease or not. We will see what is the therapy should be initiated and how it should be initiated. One of the major difference between nephrologist and the cardiologist is introduction of pillars in escalating way. Cardiologists start with pillars all at the same time. They give sodium glucose cotransporter, MRA, and ARNI, all of them at the same time initiating the therapy. We are escalating our therapy, giving ACE or ARBs first, then sodium glucose cotransporter, and if there is a residual effect and the patient is diabetic, irrespective to his heart condition, we are giving MRA late. So they are giving more bundle of therapy at the time of heart failure, and we are using very slowly escalating drugs step by step. So let us have here the starting of the what is heart failure in patients with CKD and what is the magnitude of risk. Approximately half of the patients with heart failure have coexisting chronic kidney disease, either from heart failure or from comorbidities. 70% of patients with CKD and 36% of patients with end-stage kidney disease requiring dialysis have heart failure. Now the question, how frequent you are asking for echocardiography for patients with end-stage kidney disease who are asymptomatic? I think nephrologists did not ask echocardiography routinely, although the guidelines say that we have to evaluate by echocardiography before starting dialysis and at least annually for patients who are not symptomatic and may be more frequent if the patient has cardiac disorders. So we have to implement here, asking for echocardiography for patients starting dialysis and later on annually, and putting in mind changes in dialysis or in advanced CKD may change the face in few hours. That's why approximately 87% of patients with end-stage kidney disease have major abnormalities on echocardiography before even initiating treatment with dialysis. So I am stressing here to implement in our therapy for dialysis patient to have a preliminary echocardiography like exactly virology markers. And if you watch all these specific and non-specific comorbidities were highlighted, we have chronic pressure load, we have progressive volume overload, we have cardiomyopathy that may be ischemic or non-ischemic or specific called the uremic cardiomyopathy. So cardiovascular disease in CKD, including coronary artery disease, uremic cardiomyopathy, heart failure, arrhythmia, and sudden cardiac death. If we are aware about all these items of cardiovascular disease and how to manage them, I think the outcome of our patients will be better. As Tariq said, that we have 50% death of patients on dialysis from cardiovascular disease. That may be improving by multidisciplinary team or by our awareness of the cardiovascular disorders in those patients and by monitoring of all the cardiac conditions. So we have traditional risk factors like hypertension, diabetes, dyslipidemia. We have CKD-associated factors like inflammation, oxidative stress, activation of RAS system. We have fluid overload and the hemodynamic alterations. I will highlight how to judge on the fluid overload. And we have mineral and bone disorders, vascular calcifications, and increase of FGF23. And finally, we have accumulation of uremic toxins. So patients with advanced CKD have traditional and non-traditional cardiovascular disorders. And those with non-traditional factors are in between them are modifiable factors. So if we can remove from the non-traditional factor in patients with CKD, I think we can improve the outcome to be as in general population. The problem in that is our patient has non-traditional risk factor and we are not aware about all of these items. So for nephrologists, sometimes you will read about reverse remodeling or remodeling technique. What is remodeling in myocardium? Remodeling is defined according to 5 points. It is a change in the cardiac geometry and or function over time, and it can be measured in terms of changes of what? Size, dimension of the chambers, the wall thickness, in particularly left ventricle, the volume of the heart, the mass of the heart, and finally, ejection fraction at serial imaging examinations. So we have here a lot of remodeling, and we can reverse the remodeling, for example, control of diabetes, hypertension, hyperlipidemia, volume overload status. All of them we can reverse the remodeling effect of the heart and better cardiovascular outcome. We can have here sex, gender effect, etiology, heart failure durations, left ventricular ejection fractions, other biomarkers, and gadolinium enhancement MRI. I will have 1 or 2 photos for the gadolinium, and adverse remodeling effect. So we have a multifaceted organ crosstalk. Various mediators and mechanisms contribute to the development and progression of cardiovascular disease with CKD. Also, we have complex interaction of factors characterize the multifaceted organ crosstalk in the cardiovascular system. And if you can see heroic graph coming from the probability of cardiovascular mortality risk across different CKD categories. And if you watch that, even patient with stage 3A, they have higher risk if they have heavy albuminuria. So patient, not only patient on dialysis have higher risk, even patient with a GFR 25 or 28, but still have albuminuria, they have 4x higher of cardiovascular disorder and cardiovascular mortality. So my second message is, don't give the patients that you are happy that his albuminuria is only 500 or 600. Any number above 300 milligram per gram of albuminuria carry more than 5x risk of cardiovascular disease and mortality. We have to control the GFR better, and we have to control albuminuria, because albuminuria alone carry a risk. And I will let you see one of the very, very important slide, how it is albuminuria per se can have cardiovascular death. So we have chronic kidney disease sharing some of the cardiovascular disease like activation of RAS with sympathetic nervous system. We have sodium retention, fluid retention, and oxidative stress. We have hypoperfusion of the kidney from heart failure. And we have congestion of the venous system of the kidney also from heart failure. And the pillars, the difference between us and the cardiology, we are going for more and more slowly escalating doses. We cannot use all of them at once. We have to change our mind about starting all of the pillars in presence of heart failure by the multidisciplinary team. Coming to one important of our daily activity, coronary microvascular dysfunction. Patient may have ischemic heart disease, and still his coronary microvascular has been defected, which is a key step in the development of uremic cardiomyopathy. So we have here not only atheromatous heart disease by the mean of big atheroma, we have a microvascular dysfunction. And this microvascular dysfunction coming from CKD by increasing RAS, preload after load, lower carnitine, hyperphosphatemia, cardiotonic steroids, and increase of FGF23 and lower cholesterol. So we have here specific chronic kidney disease parameters to induce microvascular dysfunction. And for the diagnosis of cardiomyopathy related to CKD, we can have here electrocardiogram, transthoracic echo, cardiac MRI, and the cardiac scanning, PET scanning or nuclear scanning. And you have different therapeutic polypharmacy, dialysis, hemo or peritoneal, transplantation. Still, patients on transplantation has higher cardiovascular death rather than the normal population. So renal transplantation does not solve 100% the problem of the cardiovascular disease. So we have challenging in patients with CKD attributed to atypical symptoms and reduced specificity of cardiac biomarkers. You cannot diagnose acute myocardial injury or myocardial infarction by simple one test of troponin or high sensitive troponin, and will come that because already patient with CKD has upper limit of cardiac troponin. We have chronic elevation of troponin level in patients with CKD require dynamic changes, not single changes, to enable the detection of acute cardiac injury. And interestingly, each 15 milli drop in the estimated GFR was associated with 40% higher threshold of the high sensitive troponin test. We also have a nephrologist barrier against contrast use and should be in mind. Considering heart failure with preserved ejection fraction, it's commonly present and more common nowadays rather than reduced ejection fraction. And it may be related to multi-system effect. And if you have such heart failure, for those patients, with acute kidney injury, so acute declining function of the heart failure, calling the type 3 cardiorenal syndrome, even acute kidney injury with oliguria and positive biomarker of kidney injury is associated with lung injury like lung edema, respiratory distress, hypoxemia, and cardiac injury. So AKI can induce cardiac arrhythmia, diastolic heart failure, and systolic heart failure, and even myocardial infarction. So heart failure traditionally is the commonest is what's called the diastolic dysfunction. The name had been changed to preserved ejection fractions. And heart failure with reduced ejection fraction when the ejection fraction is below or equal 40%. In between are the medium reduced ejection fraction, and I think literature are more focusing on the preserved and reduced ejection fraction, not on the medium reduced. But interchangeably, meaning that we may have from reduced to preserved and the reverse. For the first point, what about aging? There is increased aging worldwide, and increasing aging meaning increase more damage to organs. For heart disease and for chronic kidney disease, aging process in the heart including fibrosis, inflammation, diastolic dysfunction, mitochondrial dysfunction, and apoptosis. So aging process on the heart carries also problem and carry also probability of having heart failure higher than younger age. On the same way, CKD accelerate organ aging for the brain, cardiovascular, liver, metabolic, and pulmonary. So if you present both cardiac problem and kidney problem, the aging process will be higher. For the gender effect, yes, female are more having preserved ejection fraction heart failure, while males have more reduced ejection fraction heart failure. Also, females have more cardiomyopathy, but males have more atherosclerotic cardiac disease. So there is some disparities between the gender in diagnosis of heart disease between males and females. And in this study, CRIC study, which is a chronic renal insufficiency cohort study, they find that women had lower risk of cardiovascular event and cardiovascular mortality compared with men, which were not explained by measured risk factors alone. Also, atherosclerotic cardiovascular disease among women compared to men, they attenuate fully with lower estimated GFR. So males and females with lowering the estimated GFR, the equivalence between males and female may be in parallel. So association with estimated GFR drop suggests an important contribution of kidney to the development of cardiovascular disease type. So protection of women with advanced CKD is lost against the gender factor. But in dialysis, females die more with for all-cause mortality from drop of dialysis and infection rather than from cardiovascular. Dialysis withdrawal is much higher and infection death is much higher in females, not in males. So this is my first point. My second point, what is the major adverse kidney events and cardiovascular disease? Equivalent to major adverse cardiac events, we have major also adverse kidney events, including in this category the heart failure, AKI episodes, dialysis, and others. Even for simple proteinuria, we have activation of the RAS and volume overload. Let us have a couple of slides on albuminuria effect. For albuminuria, there is increased risk of clotting, increased risk of cardiac progression, and even in our treatment. In this study, recently published 1 year, showing that Patients with glomerular disease, higher risk of cardiovascular event associated with cumulative exposure to calcineurin inhibitors or cyclophosphamide. And this is for the target. If you have a proteinuria above 4 grams per deciliter, you have more hazard ratio, and then you stabilize. So the cutoff here for this study increasing for the albuminuria, increasing in the hazard risk, but when they are stabilized at 4 grams and more, there is the same hazard ratio. And this is the hazard risk is about 3. So it's high. And when this study, really, I was very astonishing and panic, because it's more than 6 million of participants for young individuals, 20 to 39 years. They found that proteinuria is associated with an increased risk of sudden cardiac arrest in young population. Really, that was a first information while reading, and just published a couple of months on March 2025 on the American Heart Association on a long and huge number of patients. So we have here age and gender effect. We have major adverse kidney events, and coming to our ground for the diuretic. Let us have a couple of slides on the diuretic resistance. We know that we are in phase of hepatic congestion, inferior vena cava congestion, renal congestion with heart failure. The only way we give is with diuretics. But does it work, the diuretics, in patients with CKD? We have different challenges here. We have variable of the GIT absorption from congestion, so IV may be better. We have hypoalbuminemia, which means less delivery of diuretic to the kidney. We have decreased kidney perfusion, meaning that the drug threshold to the glomerulus is lower. We have definitely competition for transport channels, tubular channels with urea and others. And finally, we have lower kidney function GFR. So we have 5 channels for giving diuretics in patients with advanced CKD due to absorption or hypoalbuminemia or decrease of the GFR. So what we are doing, we are giving the sequential nephron block, meaning that we are giving loop diuretics associated with thiazide diuretics. And it is of our clinical practice, and usually it works by giving that. Interestingly, we all understand acetazolamide and effect on the kidney, but it's coming again on the ground for some literature about acetazolamide in patients with kidney disease. And here is our rationale. First thing to do in patients in the ICU who are CKD and heart disorders or heart failure, to give the furosemide stress test. And if you have here the furosemide stress test, we are giving, if the patient was not on diuretic, we are giving 1 milligram per kilogram, but if previous history of furosemide intake, we give 1.5 milligram per kilogram and watch for 2 hours. If the urine output more than 200 milli after 2 hours, so the patient may respond well to diuretics. And the second approach in the ICU is to do what's called VEXAS, or venous excess ultrasound. For nephrologists, we are not expert, but just highlighting that it's available in the ICU, and it's done in 4 steps to measure the inferior vena cava first, and if it is the diameter more than or equal to 2 centimeters, we can use hepatic vein Doppler, then portal vein Doppler, and finally renal vein Doppler. What we gain is grading here, and this grading depending on the finding. And each of them will put the patient for follow-up from VEXAS 0 to VEXAS 3. For intra-abdominal pressure, what do you know about intra-abdominal pressure? It is a steady state pressure concealed with the abdominal activity. The reference standard for intermittent intra-abdominal pressure measurement is via the bladder with a maximum instillation volume of around 25 milli of sterile saline. It should be expressed in millimeter mercury, and it's normally 5 to 7 millimeter per mercury. And I am happy that I found the literature later on in the KDOQI guideline highlighting the importance of intra-abdominal pressure. While intra-abdominal hypertension is defined by a sustained or repeated pathological elevations of the intra-abdominal pressure above 12 millimeter mercury. And if above 20, it's compartmental compression of all the venous circulation, including the renal. So abdominal compartmental syndrome is defined as a sustained intra-abdominal pressure more than 20 millimeter mercury that is associated with new organ dysfunction and failure. And back again, this is one study published in New England Journal of Medicine discussing the probability of acetazolamide adding for patients with advanced CKD and heart failure. And they found some of the information that for patients carry a risk of volume status, including edema, effusion, ascites, and all of them were predictor of poor outcome. And they started using IV loop diuretics plus acetazolamide. The results was encouraging that we have better outcome for acetazolamide against the placebo for the volume status, and also the safety profile of endpoint was between acetazolamide and the placebo are nearly equal. However, it doesn't seem that we will have acetazolamide in the guideline by this small study around 500 patients from the acetazolamide group and the placebo. So we will have to wait giving or prescribing acetazolamide in those patients until proof or documented beneficial effect in patients with advanced CKD. So we have volume overload status, we have to manage, we have many tools. We can manage by automated way, bioimpedance, lung ultrasound detection of pulmonary interstitial fluid, absolute volume, blood volume monitoring during dialysis. We have many tools to adjust the volume of the patients. And here is the table, what is important. I think we may agree that one of the best bedside, simple testing, no cost, and very accurate is to do lung ultrasound. And actually in all the literature, they're describing that it's very useful in guiding treatment, especially in severe heart failure. So we can implement a bedside test in ICU to see the lines and to document that the patient volume status, is it congested or not. Coming to my fourth point, the volume overload and arrhythmia. And here, the volume overload status, we have to manage that because cardiac fibrosis, heart failure, and the other will happen. And the intra-abdominal pressure, as we discussed, increasing of the abdominal pressure. And I will stop here for one slide. Let us take this slide from the beginning. If you have a heart failure here, we will have congestion of the venous side, including the kidney congestion. Meanwhile, if you have a heart failure here, you have low or reduced cardiac output, and so you have lower renal perfusion. So if you have cardiomyopathy or heart failure, you have both effect on the kidney. One is congestion and one is lower perfusion. So diuretic will improve the congestion, but will not improve the perfusion. So medications for the heart failure to improve the perfusion is essential, hand in hand with the improvement of the venous congestion. So this is what's called intra-abdominal pressure, highlighted in the last KDOQI guidelines. And fluid overload, electrolyte, and all of them should be considered as a structural abnormality due to CKD. Sometimes dialysis carry a risk. including frailty, infection, and the dialysis loss of nutrients and antioxidants, and maybe also endotoxemia coming from the water impurities or water coming from the dialysate part from the dialysis machines. We have also in patients with heart failure and CKD have decrease of the oxygen delivery to the tissue. 30% of patients with advanced CKD and dialysis have pulmonary hypertension. It's important to document pulmonary hypertension in those patients needing more therapy and more control, because it's very common in patients with advanced CKD. And we have here in the heart, decreased oxygen delivery will induce more left ventricular remodeling. It's like a cycle. Each one gives the other. So if you are in a unit of dialysis or a nephrologist consultation in the ICU, and you need to test for the biomarkers, what do you need about the biomarker in CKD? The biomarkers are increased in both AKI and CKD without actual effect or actual diagnosis specifically for those patients. So interpretation of the biomarker in presence of AKI and CKD need attention. And in this study, which is 2,000 patients, they found that ambulatory CKD population with no self-reported cardiovascular disease, they don't have cardiovascular disease, they have had concentration of NT-proBNP and high sensitive TNT above the conventional upper limit, meaning that interpretation, or we need more level of patients with CKD, which are specifically for those patients as the cutoff value for diagnosis. Subsequently, the trend in the biomarker is important rather than single measurements for a time. The same finding, and all of them are considering that. I will pass FGF23 because it's very long to discuss, but retention of FGF23 occurs very early in CKD as an effect of phosphatotic effect needing to be initiated by FGF23, but it also has problem on the heart, in particularly remodeling and left ventricular hypertrophy. What about cardiac arrhythmia and sudden cardiac death in patients with renal failure? We have specific causes like CKD, MBD, we have anemia, we have left ventricular hypertrophy, myocardial fibrosis, and you have a specific cause like oxidative stress and inflammation can induce arrhythmia, and the common is atrial fibrillation. Dialysis prescription can improve and can worsen the arrhythmia in the 4 items. In the bicarbonate, avoid low calcium and low potassium dialysate in combination with high dialysate bicarbonate. So we are not going more for bicarbonate more than 32 millimole liter, especially in patients with QT prolongation. And especially if you are giving antibiotics for the castor of anything, for drugs like macrolates or quinolones, known to have QT prolongation or antiemetic, and they are using low calcium dialysate, sudden cardiac death will happen. For the dialysate potassium, avoid lower than 2 millimole per liter. For the calcium prescription, between 1.25 and 1.5 millimole as a clinical guidelines. Avoid low calcium dialysate with patients known to have QT prolongation. So back again, we have to evaluate the patient with echocardiography and ECG frequently. If the patient has long QT interval prolongations, they will have more risk of sudden cardiac arrest, even patient with normal electrolyte. And finally, magnesium. We should have a higher cutoff for magnesium in patients with end-stage kidney disease, because magnesium depletion during dialysis predisposes for arrhythmia. So in Japan, for example, they are using a cutoff of above 2.5 to 3 millimole per liter as serum magnesium for those patients, which is extremely nearly 50% higher than in normal population, because magnesium shift during dialysis immediately, and in presence of hypokalemia, the arrhythmia can occur. So we have reversible factor to prevent arrhythmia and cardiac death from our prescription. And this is what highlighted that for all patients on azithromycin or fluoroquinolones or amoxicillin exposures, they found that in presence of hyperkalemia and gap between dialysate and potassium, you will have a sudden cardiac death from those patients. And when to decide to give anticoagulant for patients with atrial fibrillation. Number one, we have to measure the risk of bleeding and thrombosis, because patients on CKD have both. They have increased procoagulants, they have reduced anticoagulant like antithrombin, we have platelet leukocyte aggregation. So patients on hemodialysis on advanced CKD have higher coagulation factors. That's why they have 10 times increased risk of cerebrovascular stroke. On the same way, patients with advanced CKD have also bleeding risk. So the balance is important. And increased bleeding risk from oxidative stress, platelet activation during dialysis and consumption, and decrease in thrombexan A2 and adhesion or aggregation. So let us have what the guidelines say, or what is the recommendations for atrial fibrillation and anticoagulation. We have here this list. We have to consider the vascular score for risk benefits of anticoagulation. Number two, you have to define if you are treating atrial fibrillation due to valvular or non-valvular. If it's a valvular, no way you have warfarin. If it's atrial fibrillation without valvular, you can use direct oral anticoagulations. On what doses? We are usually giving the smallest dose, which is for apixaban, 2.5 milligram twice daily. And this is for the recommendation if you have a creatinine clearance below 15 milli per minute or dialysis dependent. And it's more superior than rivaroxaban. Be in mind, these doses for atrial fibrillation, only for atrial fibrillation without valvular lesions. But the patient is have venous thromboembolic disorders, no dose reduction, because you are treating venous thromboembolism, critical. So even in patient with creatinine clearance below 15 milli per minute, you have to give loading dose, then full dose of apixaban 5 milligram BD, irrespective of the creatinine clearance. So giving or prescribing anticoagulant, number one, we have to decide the risk benefit. Number two, patient with atrial fibrillation due to valvular or non-valvular. If valvular, we go directly with warfarin. If no valvular, we can go with DWAC for small doses of apixaban. But if the patient experiences thromboembolic disorders, then we have to give the full doses. So the recommendation that the use of DWAC in patient with end-stage renal disease requiring renal replacement therapy and in kidney transplant recipient require careful consideration. Both apixaban and rivaroxaban may have more or less pharmacokinetic profile مختلف. نتيجة لذلك registry evaluating the patient still there is no strong recommendation from nephrology perspective, but we have recommendation from other societies like cardiology society and others. Coming to my end of the talk, we have guideline-directed medical treatment. We have the guideline-directed medical treatment. We have many of our evaluation like cardiac CT, imaging, nuclear cardiology. we have to do risk stratifactions and personalized dialysis. I will prescribe the dialysis for patients on heart failure. And we have to do what's called cardiovascular complications, to mention uremic cardiomyopathy, calcinosis, and uremic cardiomyocytes and pericarditis. So let us have here what's called cardiac calcification score. 20 years ago, or maybe more, I was supervising an MED in our department. 20 years, we found that more than 40 to 50% of patients has cardiac calcification score high, and those patients eventually have different score from 0 to 400. I will let you see that. This is the scoring system, and the white is the calcification of the coronaries, and you have 0, no calcium is detected, 1 to 100, mildly increased risk of heart disease, up to 300 moderate increase, and more than 300 moderate to severe increased risk of heart disease. So cardiac calcification could be found by MRI or by CT scan, and you can have to calculate that calcification score. And for sure, CKD mineral bone disease plays a major role in cardiac calcifications. To adjust the PTH, to adjust phosphorus and the calcium, moving from calcium-based to non-calcium-based phosphate binders will help the patient. And this is the coronary calcium calcification in this diagram and how to assess. And let us have some slides here from a radiology point of view. So coronary calcification scan can detect coronary calcium. Any calcification will appear. And this is the grading from low risk to mild to moderate or to high risk chance. Unfortunately, those patients will not get benefit from revascularization because usually the calcified arteries will not be possible to be dilated except very early. So diagnosis earlier is better. And this is one example of calcification. And if you're still here, our colleagues, what's your diagnosis in this case? This is one of the radiology, and you can find that you have here this is an X-ray showing this white part of the heart. So what's your diagnosis? Yes, exactly. It's a constrictive pericarditis or constrictive heart. You cannot diagnose clinically except by imaging. So we have to monitor your patient. And what about this? What's your diagnosis? Again, you cannot diagnose except by imaging. This is a pericardial effusion, correct? This is the plaque space here is the pericardial effusion. And this is heroic picture of calcification everywhere, of the heart, of the pericardium, of the vasculature. So this is calcifications or cardiac calcinosis, huge calcification of the heart. Simply, we have to follow the guidelines of the calcium phosphate parathyroid hormone to be normalized as much as we can to prevent vascular calcification or metastatic calcification. So, last points. What about cardiac medication? What is the rule in CKD? Beta blocker, ACE, ARNI, MRA, and sodium glucose cotransporter. Unfortunately, we have CKD and cardiovascular disease, a two-way street. So if you improve cardiovascular, you improve the CKD, and we have improvement of CKD, you will improve the cardiovascular and the reverse. but the availability of drugs is different. So if you have management of patient with heart failure with preserved ejection fraction, you have diuretics, you have sodium glucose cotransporter, you can treat the etiology, cardiovascular and non-cardiovascular comorbidities. And this is the doses you can start with in patient with CKD and the monitoring. We have ARNI, sacubitril, valsartan. We can start a smaller dose, like 50 milligram twice daily, then upgrading according to the hypotension and hyperkalemia. We have beta blocker, all doses of the beta blocker. You can take a snapshot for dose adjustment, metoprolol, bisoprolol, carvedilol. Most of them are not dialysable and no dose adjustment for those class of beta blockers. So we have to think about bisoprolol, metoprolol, and carvedilol. For the ACE inhibitor, most of all ACE inhibitor have dose adjustment or dialysability. I think we all are going to more for ARBs for patient even with advanced CKD or on dialysis because they are not dialysable. So losartan, valsartan, irbesartan, and candesartan, most of them no dose adjustment. So consistency of therapy is important in giving ARBs more than ACE inhibitor. And the guidelines say any of them, ACE versus ARBs. Makes no difference between the two classes. For the MRA, eplerenone, phenrenone, we don't start if the GFR is below 25 milli per minute. And for eplerenone, we don't start even at a higher level because hypotension and hyperkalemia is high. But phenrenone, the risk of hyperkalemia is low. So phenrenone starting above 25 milli per minute and contraindicated when GFR below 25 milli per minute. For the sodium glucose cotransporter, we have to start above, but if the GFR drop below 20, we have to continue till dialysis. And this is the last applications recommendation for the drug dosing for heart disease and kidney disease. So we have beta blocker, ARNI, RAS, MRA, sodium glucose cotransporter. Best treatment management for patient with HFrEF. And similarly, patients with heart failure are not eligible for initiation of multiple guideline-directed medical treatment. All the list except the ARNI may not be suitable to start for patients with end-stage kidney disease. There is some trials for the ARNI for the use. And this ARNI can overlap the barrier. And this is the guidelines saying that no guidance for the dose for heart failure, no guidance on dose or order of introduction. For heart failure with end-stage kidney disease, no guidance. All are مشطوب عليهم ACE inhibitor, MRA, sodium glucose cotransporter, just giving the only ones considered the beta blocker. And from the guidelines saying that we can escalate the dose of the medication according to the current estimated GFR. You can start by ACE, ARBs, and ARNI or ARNI, any one of them. You can add later on carvedilol, metoprolol, titrated, bisoprolol. You can add mineralocorticoid antagonist. And finally, digoxin, which is completely nowadays is rarely be used. From this screen, you can find that for patients with end-stage kidney disease with heart failure, no guidelines saying any of them or how to start or how to implement a new treatment on that. So all of them are off-label use for patients with end-stage kidney disease. However, ARNI are more better for the outcome for the all-cause mortality, not the cardiovascular mortality. They don't reduce hospitalization rate. And conflicting result for the cardiovascular mortality in end-stage kidney disease or ARBs higher discontinuation during hypotension, hyperkalemia in patients with advanced CKD, but insights coming from sacubitril, valsartan, ARNI treatment are well tolerated in patients on dialysis. This is 12 studies meta-analysis, around 800 patients end-stage kidney disease on dialysis, and they're suggesting that sacubitril, valsartan benefits for those patients by titrating the doses starting from 50 milligram and up escalating the dose according to the patient tolerance. And this is the results coming from the New England, from the JAMA 2024 for the sacubitril, and even they finding, I think, astonishingly, I found this paper that they measure the arteriovenous fistula with heart failure treated with sacubitril valsartan is associated with improvement in left ventricular ejection fraction and fistula flow over 12 months. For the sodium glucose transporter, we don't have any data up till now. There is current trials is going for patients with end-stage kidney disease, but we don't have. The same happened here for sodium glucose transporter. There is no randomized control trial in advanced CKD in patients. For the MRA use in patients with end-stage kidney disease, there is no data. However, likely safer in peritoneal dialysis compared to hemodialysis because of the continuous dialysis procedure of peritoneal dialysis, meaning less likely of hyperkalemia. With the introduction of phenrenone, also the presence of hyperkalemia is less than with spironolactone or even ibuprofen. And here is the guideline saying that once your estimated GFR normal up to 30, you have plenty of medication to give in patients with heart failure and CKD. We have MRA, isoserpide, hydrolazide, ARBs, ACE, beta blocker, and carvedilol. Once you have dropped it below 30 ml/min GFR, the probability of medication is decreased. And if you are here between 10 to 0, which is the end-stage kidney disease or dialysis, all of this medication except the beta blocker may be allowed by the guideline-directed medical therapy. So treat your patient earlier for heart as better for the outcome before going to stage 5, and you cannot find medication to give, or risk-benefit ratio is higher for those patients. Finally, and rapidly, what about mechanical ultrafiltration in heart failure? What's called in nephrology field sequential ultrafiltration, or by what's called aquapheresis. Improve the congestion, and if you improve the congestion, decrease the inflammation and the endotoxin translocation from the gut. So it gets a beneficial effect. And as discussed before, that venous congestion decreases the renal function because for the congestion effect of the venous veins. And there is some report here by the Kidney International published January 2025 that hemodiafiltration, high volume, and the low ultrafiltration rate help to preserve the hemodynamic stability and gut tissue perfusion. So one possibility of treating patients with heart failure on dialysis is to go directly to high volume hemodiafiltration, better than conventional dialysis. And the second point is to do sequential ultrafiltration, or the what's called here the aquapheresis. Aquapheresis is not a dialysis. It's using a very tiny filter, 0.2 square meter surface area. It's a bedside, does not need a central line or a catheter. It may be on peripheral vein. It's portable, and ultrafiltration is guided by the level of hematocrit. So once you have an increasing hematocrit, you may stop. The usual rate of ultrafiltration between 100 to 300 milli per hour, and you can do it guided by the hematocrit. But does it help or not? We'll see that on the benefit of sequential ultrafiltration or aquapheresis against the sequential nephron block by diuretics. We have different studies, the unload, the CARIS, and the avoid heart failure studies, and the recommendations that it's a transient intravascular depletion, maybe an initial divergence from expected clinical term. Clinicians should note that flexible ultrafiltration rate is guided by the clinical and biochemical pictures. Ultrafiltration appears to be most beneficial when earlier. You can do furosemide stress test. You can do VEXAS or lung ultrasound to decide earlier than expected that you can start sequential ultrafiltration. However, ultrafiltration will not improve cardiac biomarkers when used, and definitely may maintain decongestion support over diuretics, but will not improve the mortality. It improves only the hospitalization and rehospitalization rate. Don't miss that to control all of the patients with heart failure in the diagnosis. Sleep apnea syndrome is common in patients, obesity, nutritional management, physical activity, control of anemia, and volume of control. And to do dialysis, you have to do dialysis very slowly and very, very gently in ultrafiltration, as those patients will not tolerate too much of the volume because of low ejection fraction. So more or less, very slowly and very gentle dialysis with prolonged time and more achievement by hemodiafiltration technique. You are doing more and more by more daily dialysis or nocturnal dialysis, or even 6 to 8 hours, 3 times per week dialysis will be better for patients. Finally, my dear friends, by these conclusions that every solution of a problem raises new unsolved problem. Still, we are waiting for the guidelines of heart disease in patients with advanced CKD to monitor the treatment and to improve the patient's outcome. Using dialysis perfectly in the right time, in the right dose, and the right duration may improve the patient outcome. And this is just one paper. If you want to have a screenshot for how to treat systolic dysfunction, you are using carvedilol. Diastolic dysfunction, to reduce left ventricular mass, consider ACE/ARBs or MRA if eligible. Minimize arrhythmic triggers by control of potassium in dialysate, dialysate calcium, control of metabolic acidosis, and avoid high dialysate bicarbonate. Remember not to do rapid ultrafiltrations. Don't do too much ultrafiltration in shorter time. For medication, avoid QT interval prolongation medication when possible, and always risk and benefits for other intracardiac devices for the cardiologist team. Thank you very much. I hope that it was informative, and we can change our practice according to all of this literature. Thank you very much.
Many thanks, Professor Hisham, for your elegant presentation. As usual, it was wonderful and helpful for us.
I hope that it wasn't boring.
No, this is very simple. My way, and also it's practical. Many thanks a lot. I consider it as a present my birthday today. I have today my birthday, so it is a great present.
Happy birthday.
Thank you. As regard the ARNI in our daily practice, we consider it not be used when GFR is 30 or less than 30 milli per minute. In